Hi, I'm Kiho Park from Seoul National University. I'm very pleased to share with my slides with the AIOS. Thank you so much for your kind invitation. I'd like to appreciate Tanus for your kind invitation. So I'm going to share with you about the OCT to distinguish myopia from glaucoma. Glaucoma is a leading cause of blindness worldwide, and there's optic nerve damage due to loss of retinal ganglion cells and their axons. And there is characteristic visual field loss. At the beginning, we looked into the optic nerve head to diagnose glaucoma. After that, we also look at the retinal nerve fiber layers for the defect. And recently, after development of OCT, we're also looking at the optic nerve and retinal nerve fiber layer thickness. And also, we look at the retinal ganglion cell layer in the macula. So this is the structure and function relationship modified by Dr. Madero's paper. At the beginning, this graph is glaucoma progression according to the visual field and retinal nerve fiber layer thickness. So the left side is the glaucoma progression direction. So at the beginning, visual field change is slow, what we call that ceiling effect. Compared to that, retinal nerve fiber layer change is faster at the beginning, and it reaches plateau, which we call that floor effect at the later stage. But the floor effect of retinal nerve fiber layer begins quite late in the advanced stage, with mean deviation around minus 27 decibels. So even in advanced glaucoma, both visual field and retinal nerve fiber layer evaluation can be useful to detect glaucoma and to detect progression. About 30 years ago, the first OCT prototype was invented, and the OCT has developed very fast. Now we have OCT spectral domain OCT and swept source OCT as well. So at the beginning, using time domain OCT, our group has investigated the correlation between RNFL photograph and time domain OCT. And we showed that the correlation was very good, as you can see in the infratemporal RNFL defect in the right eye, which has been detected by time domain OCT here. And also in the left eye, superatemporal and infratemporal RNFL defect could be detected by time domain OCT thickness curve and plotwise deviation, color-coded deviation comparison diagram. In the RNFL photography, we can clearly detect RNFL defect. In this case, superatemporal and infratemporal defect. After 4 years, you can see the width of the defect has been increased, both in superior and inferior. So photograph is a very good tool to detect early RNFL defect and also to detect progression. This is a case with a glaucoma suspect by fundus photograph taken at the routine health checkup. At the beginning, at the time, infratemporal 7 o'clock position disc hemorrhage was detected, and retinal nerve fiber layer defect was not clear. And also, we could have 2006 photograph as well. At the time, RNFL was RNFL photograph showed no abnormality, and we followed up this patient for about 10 years, and we found that there were recurrent disc hemorrhages and also corresponding retinal null fiber layer change intertemporally. So you can see clearly the RNFL defect has been progressed after 10 years from the detection of first disc hemorrhage. The visual field was normal until the last follow-up visit, and if we look at the OCT images, we can see clearly RNFL defect and GCIPL defect at the 2012, and the visual field at that time was within normal. So even though visual field by standard automated perimetry was within normal, the RNFL and GCIPL defect was detected at that time, and they progressed until 2019, and you can see clearly the larger area of retinal ganglion cell defect compared to the retinal null fiber layer defect. And GPA analysis could detect significant progression in GCIPL analysis. As you can see, this orange and the dark red colored area. In visual field, we can perform glaucoma hemifield test, and outside normal finding was shown in this visual field. So the superior and inferior visual field asymmetry could be detected using this glaucoma hemifield test. Similarly, in GCIPL analysis thickness map, we can compare the superior and inferior GCIPL thickness across the horizontal raphe, and we call that GCIPL hemifield test, and this difference could be detected in glaucoma. We call that temporal raphe sign positive. And if we follow the POH patient with early cases, those 94 eyes with the ganglion cell GCIPL loss was followed up for 3 years, and among them, about 20% showed corresponding RNFL defect later. However, in the opposite case, 52 eyes without GCIPL loss at the beginning. Among them, after 3 years follow-up, only about 2% of them showed corresponding RNFL defect appeared later. So that means in most cases, GCIPL loss was detected first and followed by corresponding RNFL defects. And our cases were mostly normal tension glaucoma patients, because in Korea, about 90% of POHs are normal tension glaucoma. And similar finding was reported by Australian group that, as you can see in NTG patients, about 2/3 of them showed GCIPL loss first compared to the RNFL defect. However, in the high tension glaucoma eyes, less than half of them showed GCIPL loss first compared to the RNFL defect first. So our report, in which most of the POHs were normal tension glaucoma, has same result with those Australian groups' results. And in a ganglion cell inner plexiform layer, analysis can be helpful in moderate to advanced glaucoma progression detection. As you can see in this survival curve analysis, in moderate to advanced glaucoma, GCIPL thickness showed better diagnostic ability to detect progression compared to the RNFL thickness. So in addition to this visual field and RNFL curve, we may add a GCIPL curve like this. So at the beginning, GCIPL change was better than visual field or RNFL change because the change is faster in early cases. And it showed less floor effect at the advanced stage compared to the RNFL curve. So we may combine RNFL and GCIPL thickness map and also deviation map and thickness analysis to detect glaucoma early. This is case showing comparison between the spectral domain OCT and swept source OCT. In spectral domain OCT, sometimes peripheral RNFL defect could be missed here. But if we perform wide scan by swept source OCT, those peripheral RNFL defect could be detected. So wide field swept source OCT analysis may be helpful to detect those kind of peripheral RNFL defects. Let me share with the cases with myopia eyes, how to detect myopic glaucoma in OCT. In East Asia, the prevalence of myopia is very high, as you can see in this yellow area. China, Korea, Japan, Taiwan, and Singapore. This graph clearly shows in recent 80 years or 90 years, the dramatic increase in myopic eyes is shown in Taiwan, Singapore, Hong Kong, and Korea. So nowadays, myopia is a big problem because it induces many retinal problems and also glaucoma as well. And as you can this graph, Korea has the highest prevalence of myopia and high myopia among those Southeast and East Asian region. Myopia is known as a risk factor of glaucoma, but the diagnosis of glaucoma in those myopic eyes is challenging because the glaucomatous change and myopic changes is similar and difficult to differentiate. And there is disc tilt and peripapillary atrophy and chorioretinal atrophy, which inhibits diagnosis of glaucoma. And there is eyeball elongation, which induces a poor quality of imaging by photography or OCT as well. In OCT, care should be taken to differentiate true defect from pseudo-abnormal RNFL defects. Because of eyeball elongation, the temporal convergence of supertemporal and inferior temporal RNFL bundles thickness peaks moves temporally, as you can see in this graph. And also, if you look at the healthy myope case with minus 6.5 diopters from my patient on the right-hand side, the temporal convergence of the superior temporal and inferior temporal bundles makes pseudo defect compared to the normative database, because the normative database is not myopic normative database. These temporal convergence of the RNFL thickness curve makes pseudo defect here, here, and here. So in the deviation map, you can see the red colors in the superior and inferior area of this map. So this is a pseudo defect, not true defect. It is, we call that red disease. So we need to differentiate those when we interpret OCT results in myopic eyes. So Dr. Chris Lung's group and our group has shown that using myopic normative database in OCT can remove those red disease, those pseudo defects, as you can see in the figure on the left. And also those pseudo defects could be removed by myopic database. And we compared the detection ability of ganglion cell inner plexiform layer thickness, the GCIPL thickness, with those of RNFL thickness. And we found that AURC of inferior peripapillary RNFL and inferior temporal GCIPL values were not statistically significant. So our conclusion was that in case of high myopia, the glaucoma detection ability of macular GCIPL thickness was high and comparable with that of peripapillary RNFL thickness. This is a case with minus 5.8 diopters, moderate myopia with axial length of 25.62 millimeters. And mean deviation was -2, so it's an early glaucoma case. And you can see there are red area in the deviation map. And the thickness curve, you can see the peak was temporally shifted, both superior temporal and inferior temporal part. And we can see the red disease in this superior area, because the peak was superior peak was temporally moved. And true defect was inferior temporal area here. So if you review the RNFL photography, you can see there is a RNFL defect in the inferior temporal region here, and it is detected by OCT deviation map here. So this is real defect, inferior temporal region. And if we look at ganglion cell analysis, these real defect could be detected more clearly, and larger area of defect could be detected. So in this case, we can look at the ganglion cell analysis, and temporal rapid sign is very clear. It helps to detect glaucoma true defect. This is another case with high myopia with -7 diopter, and axial length was longer than 28 millimeters, and visual field was within normal, but there are inferior temporal RNFL defect, and deviation map shows two defects, inferiorly and inferior temporally. And the thickness curve is like this. You can see the dotted line because it is the left eye. And you can see here, it is a pseudo defect because of peak shifted temporally. You can see pseudo defect inferiorly. And true defect is here, inferior temporal part, which corresponds with the RNFL defect in the photograph. And ganglion cell analysis could show clearly the inferior ganglion cell analysis, inferior ganglion cell layer thickness change, and we call that temporal rapid sign positive. This is more highly myopic eyes with very poor image in the null fiber layer photograph. So we cannot see clearly whether the null fiber layer is thinned or not, because the fundus color is very tigroid, and the pigments are quite much. So we perform OCT, and you can see red disease in superior part and also red disease in the inferior part. But the real defect was at the inferior temporal area. And you can see the temporal rapid sign in this case as well. So even though the RNFL photography quality is poor, in this case, we can have inferior temporal RNFL defect detected by spectral domain OCT. So same slide I showed here previously, the GCIPL hemifield test and temporal rapid sign is helpful in myopic eyes as well, because this temporal rapid sign does not require normative database. We just compare the superior thickness and inferior thickness in the ganglion cell thickness map. So we may avoid pseudo defect in this glaucoma GCIPL hemifield test. So this GCIPL hemifield is asymmetry temporal rapid sign in highly myopic eyes was investigated, and we found that GCIPL thickness difference across the horizontal rapid in high myopia is useful, and it has high AURC values, as you can see here, compared to the RNFL thickness and GCIPL thickness. So temporal rapid sign is useful in highly myopic eyes. Another thing is neuroretinal rim width in spectralis OCT. We call that BMO MLW. So the distance from the BMO opening to the Brooks membrane, from the Brooks membrane opening to the internal limiting membrane. So it's a minimum rim width. Similar concept is in the serous OCT. We call that three-dimensional neuroretinal rim thickness, 3D NRR thickness. So the thickness was measured from the Brooks membrane opening to the vitreoretinal interface. So in myopic glaucoma, we investigated this three-dimensional neuroretinal rim thickness, whether it is a good ability to detect glaucoma in those myopic eyes. So this is the result, that RNFL thickness could not clearly differentiate between the glaucoma from the red disease pseudo defect colored in red graph here. Normal is green here, and glaucoma is gray line here. But 3D neuroretinal rim thickness clearly differentiate glaucoma from a red disease and glaucoma from normal as well. So compared to the RNFL thickness, 3D neuroretinal rim thickness clearly differentiate glaucoma from normal and red disease. And this is a case showing there is a red disease and also some not clearly differentiate the glaucoma case with normative database, but you can see neuroretinal rim thickness could detect abnormality in the superior and inferior area. So we can combine both 3D neuroretinal rim thickness and RNFL thickness and also GCIPL thickness to detect glaucoma in myopic eyes. Another example is comparing the spectral domain OCT and swept source OCT. This is healthy myopic eyes with -11 diopters, and it shows red disease in spectral domain OCT. You can see red disease here inferiorly and ganglion cell layer here. But swept source OCT did not show any abnormality. It did not show red disease, did not show pseudo defect. I think it is because the normative database is different between spectral domain OCT and swept source OCT. So sometimes swept source OCT could be helpful to detect glaucoma and to detect normal in myopic eyes. So we may use both instruments, and we may need to compare it if the case is not clearly to detect glaucoma. This is another paper comparing spectral domain OCT and swept source OCT in myopic eyes. So more than 100 cases of pre-perimetric glaucoma, 104 perimetric glaucoma, and 46 pre-perimetric glaucoma were enrolled in myopic eyes. And swept source OCT could create RNFL plus GCL2 plus, which means GCC in Optoview, including RNFL, GCL, and IPL. And it can be combined with RNFL analysis. So in this figure, those RNFL and GCL2 plus is combined. And also, RNFL could be combined with the GCL plus, which means GCL plus IPL layer, GCIPL layer in a serous OCT. So RNFL and GCIPL deviation may be combined like this. And swept source OCT showed better accuracy than spectral domain OCT in myopic eyes. As you can see in green area, which means swept source OCT measurement is significantly superior to that of serous spectral domain OCT. So RNFL thickness, GCL2 plus versus GCIPL thickness, and GCL plus versus GCIPL thickness, those circumstances, swept source OCT showed better accuracy in those sectored area. So I think it is because swept source OCT had wider area of scan, and also it has its own normative database. The last part is disc hemorrhage in myopic eyes. In myopic eyes, the prevalence of disc hemorrhage is lower than non-myopic eyes, but if it is detected, it helps to diagnose glaucoma, because disc hemorrhage itself is quite specific for glaucoma. So we investigated the myopic eyes, whether the disc hemorrhage is useful to detect subsequent glaucoma progression. So for the structural progression, disc hemorrhage positive eyes showed significantly faster progression compared to the disc hemorrhage negative eyes. But in functional progression in our study, I think it is because of the follow-up period was not long. There was no significant difference between hemorrhage positive and negative eyes and functional progression. But for the structural progression, there was a statistically significant difference. This is the representative case. You can see recurrent disc hemorrhage here, and now the disc hemorrhage at the beginning here. So there were 3 recurrent disc hemorrhages, and the RNFL, 4 recurrent disc hemorrhages, and RNFL defect was increased here, and also it was the width was increased here. So even in myopic eyes, disc hemorrhage is a very useful sign to detect glaucoma and also to detect progression. This is a case, last case, 46-year-old gentleman. LASIK surgery was done 20 years ago, and pre-LASIK refractive error was -11 diopters. IOP was 9. You can see inferior temporal and superior temporal retinal fiber layer defect. Disc was tilted, and also neuroretinal rim was thin in superior and inferior part. Visual field was normal, and OCT is quite irregular. Some red disease was mixed, I think. And those high myopic eyes after LASIK surgery, the quality of OCT is poor. You can see the signal strength is 4. So in those poor OCT images, we cannot clearly say these eyes are glaucoma or not, and the temporal rapid sign was not clear as well. So in those eyes, close-up investigation of the optic nerve head, and also look at the retinal nerve fiber layer photograph may be more helpful than OCT. So these are the take-home messages. In myopic eyes, to diagnose glaucoma, it is important to differentiate red disease from the true RNFL defect. Combining peripapillary RNFL analysis and macular analysis may enhance diagnostic ability. Minimum rim width can be complementary to RNFL thickness measurement for differentiation of myopic glaucoma from myopia. Swept source OCT wide field map showed better accuracy for glaucomatous defect than spectral domain OCT due to wider scan area. However, qualitative evaluation of the optic disc and RNFL defect by photography is still important, especially when the image quality of OCT is poor. Thanks so much for your attention.